Well, good evening, everyone who is joining us here on the Zoom and as it is being streamed on Facebook. My name is Rasan Hall. I am the president and CEO of the Urban League of Eastern Massachusetts, and we are proud to partner with AdMeTech on this important conversation about prostate cancer awareness. As we all know, prostate cancer is a significant health concern, particularly for communities of color in Massachusetts. And it's important that there is early detection through regular screening, which is crucial. And it can lead to early screening, can lead to more effective and less invasive treatment options that significantly improve survival rates. And for men of color, especially Black men who are at much higher risk of developing prostate cancer and more likely to be diagnosed at advanced stages, this is a critical conversation, and that's why the Urban League takes this issue and the promotion of awareness about this issue so seriously. I've had several men in my life through my church and community who have been able to share their stories of survival, in large part because of knowledge, awareness, and early detection. I've also had to confront some of the challenges that exist within the system, having a doctor that was reluctant to provide the screening for me, particularly because I'm African American. I knew that screening was beneficial at an earlier age, but he kind of brushed it off. But I went to another doctor who said, oh, no, definitely we should conduct the screening. Fortunately for me, there was nothing wrong. But I can only imagine how many other men have had similar experiences. And so the more awareness we raise about the importance of early screening and early detection and treatment, not only for men, but for the women and other family members in their lives and loved ones who care about them, the better outcomes we will receive. And particularly now where there are assaults and threats on intentional efforts to take approaches that expand and diversify the medical profession, but also expand and diversify the outreach efforts to make sure that we are addressing disparities in health. It's all the more important that we do this work. That's why we're glad to partner with AdMeTech and Dr. Stern and her team to really continue to do this outreach work and make sure we're reaching as many people as possible. And so I have the distinct pleasure of introducing not only the senator of the 2nd Suffolk District, but also a dear friend and champion for racial justice, social justice, health, and health equity, Senator Liz Miranda, who has been a key supporter of prostate cancer educational and equity program for high-risk men. So without further ado, I will turn it over to you, Senator Miranda, to bring some welcoming remarks.
Thank you, everyone. I'm looking forward to just providing some brief remarks. And I just want to give a shout out to my dear brother, Mr. Rasan Hall, CEO and president of the Urban League. I've enjoyed not only my time in the legislature working with the Urban League, but being a daughter of Roxbury, always seeing how the Urban League has stepped up for our communities and stepped in the gap. Before I begin my remarks, I think it's with a heavy heart that I want to also acknowledge, like many people around the country and including in the Commonwealth of Massachusetts are reeling with many things. Fires are still burning in Los Angeles County. We had a passenger jet after 20 years collide with a helicopter last evening at an airport that I know I frequent a couple times a month. And there are no survivors, 6 Commonwealth residents that were on that plane. And I know some people are thinking about that. Days with new administration that has brought a lot of fear and chaos to our communities. And so I think it's important as we're talking about prostate cancer, we're actually talking about an issue of health equity. And we're talking about something really critical and important to our communities that we don't always have the access to discuss as a community. So I want to begin my remarks by also thanking my fellow speakers. I want to talk and congratulate Dr. David Einstein. Hope I didn't mispronounce that. A professor from Harvard Medical School. As a Wellesley graduate, I know that Harvard Med, is up there. So thank you, David, for not only being who you are and doing what you do, but also graduating from an esteemed institution that does a lot of research on the things that we care about in our communities. We have Dr. Stern. Thank you so much. President and CEO of AdMeTech Foundation. I'm really happy to be here. I get all the emails, and it's good to put a name and a face together to think about how we can do more work together. And I also want to talk to and congratulate Emma Couillard. Hi, Emma, Manager of Prostate Cancer Equity Program and Organizational Development. Thank you all for being here. I care a lot about prostate cancer, not because I know a lot about prostate cancer. When I learned about prostate cancer, it's when my grandfather died. My grandfather, who's a Cape Verdean man, passed away from prostate cancer in 2008. And when he passed away, we didn't know what he died from. We didn't know he was sick. And it was because he had only told one person. He had told my mother and swore her to secrecy because of the shame and secrecy he wanted to have. Because in cultural communities like Cape Verdean communities, when you're talking about something like prostate, when you're talking about somebody's private parts, it's not something that people take lightly and talk about and actually find out how they're doing. And so, my grandfather was an amazing human being, and he took care of his family and his children and his grandchildren. And it was really sad when he passed away to find out that he had something that we could have prevented in the United States. With the early detection, with the great hospitals and care that we have in the Commonwealth, we might have saved him so he could be here to see his granddaughter become a state senator in his lifetime. And it has no boundaries. And I think this is really important to share. It has no borders, and it can affect all men in America. I think, it's important to share that it doesn't matter how much money you have. It doesn't matter, your access and proximity. Prostate cancer does not have sort of a type. There's no immunity. And in fact, 13% of American men have been diagnosed with prostate cancer sometime in their lifetime. But each man's risk of prostate cancer can vary in men being more likely to receive a diagnosis. It is important to highlight, and this is the important fact, that Black men are 2.5 times more likely to develop prostate cancer. When I shared with a friend that I'd be on this call today, he said, you know something? My uncle and my grandfather passed away of prostate cancer. And, I've never talked about it. And I said, why haven't you talked about it? And I think probably the piece that, is important to share is that when we lose our loved ones, many times, if we're not in the healthcare space, we may not know what to do to not only protect our loved ones, but to protect ourselves. Black men are also more likely to develop prostate cancer at younger ages. When I talked about 65 years and older, I have a lifelong mentor of mine that developed prostate cancer at 40 years old. And he's been battling this disease for 25 years. And, he's done it with courage, and he's done it with the best healthcare that we have to offer in this country. But he always told me that he wished that he had known that he could have talked to his doctor and his provider and actually advocated for himself. I heard you, Rasan, when you shared that, it's incredibly difficult when you have a provider that doesn't want to screen you because they think you're too young. But sometimes we have family history and community history that lead us to want to get screened. So fortunately, we know that early detection and knowledge of prostate cancer has helped improve the quality of life for patients who are diagnosed in the beginning stages of this disease. And prostate cancer, though a very serious disease, is also highly treatable and curable, especially when caught early. So I want to urge the men in attendance, the men and women and their families who are online looking at this or on this Zoom today, talk to your doctors and to see if prostate cancer is in your family history, as prostate cancer doesn't just impact your health, but it also impacts and affects the loved ones that are closest to you. So thank you, Urban League, for having me tonight. Thank you, AdMeTech. Thank you to all the speakers. And I just want to encourage folks, there's a lot we can do in Massachusetts. Sometimes we feel like we're exceptional in the Commonwealth, and we have the best hospitals, best colleges, best life sciences and biotech facilities, but we can do more. We can do more for prostate cancer. We can do more for all cancers, particularly the cancers that are affecting Black and Brown communities that I serve. And I urge us all to urge the legislature to push and encourage more companies and more businesses. They're here in Massachusetts. You know, just as I was looking at my email, hearing that Vertex, just coming off of creating something to help with sickle cell, it just created a non-sort of addictive drug to help with the opioid crisis. So these companies are here. Takeda's here, Vertex is here, and many more companies that are here also doing the research that is being done at our local hospitals and universities. So thank you. Hope we learned a lot tonight.
Thank you so much, Senator Miranda, for your words, your insight, your personal reflections on this disease, which can be treated early and save lives, but also for your advocacy within the legislature and your leadership. I'd now like to introduce Dr. David Einstein, who's an assistant professor at Harvard Medical School and an attending physician at Beth Israel Deaconess Medical Center. Dr. Einstein.
Well, thanks so much for having me. I apologize, my voice isn't what it should be. I'm a little under the weather, but really honored to be here with you tonight, talking about something that's near and dear to my heart. I am a medical oncologist. I see patients with prostate, among other cancers, as my job, and I'm very fortunate to do so. I wanted to thank Senator Miranda for some of the personal words. I can't tell you how many families that story reminds me of in my clinic, where I've been treating a patient for years and encouraging them to bring in family members to talk over what's going on. And, years down the line, all of a sudden there's a surprise. So it can be a real challenge to get people to talk about these issues. So I wanted to basically frame this around a number of sort of myths, misconceptions that I hear from patients. And as with all myths, there's usually an element of truth to each one. But I want to go through each of these and sort of explain where the truth lies. The first misconception that I've heard is that prostate cancer is common, but that it's actually overdiagnosed. Secondly, everyone should get screened for prostate cancer. If I get tested, then I'll have to do all this other stuff, biopsies, surgery, radiation, and that's just going to lead to a lot of problems. We'll talk a little bit about PSA testing, but broadly speaking, there's the idea that the blood test will definitely tell you who does and doesn't have cancer. Some folks actually think it's cancer, therefore it equals a death sentence. Or if it's spread, then there's nothing the doctors can do about it. I can't tell you how many patients have said, well, I don't have any pain, so I can't have cancer. The idea that diet and exercise can actually prevent prostate cancer, again, there's going to be elements of truth to some of these, but I want to go through where the truth lies. Natural supplements might do a better job of treating cancer, have fewer side effects. If I get prostate cancer treatment, then that will lead to some real financial difficulties. And then finally, clinical trials, that's not for me. So let's go through each one of these. So these are the latest statistics from American Cancer Society, and these are estimates for 2025 based off of data from previous years. And so in men here, and by the way, for all the ladies on the call, it's oftentimes the wives and daughters and sisters who bring patients into my clinic. So this is even more important for you all to know. Up here, we have the number of expected diagnoses in the coming year, and down here, the expected number of deaths in the United States. So you can see that prostate is number one for men. We usually quote about a 1 in 8 lifetime risk. Now that actually increases to about 1 in 6 men of color, especially Black men. You'll see down in the deaths part that it is number 2. And actually lung cancer is rapidly falling, which is great, and the result of a lot of hard work in reducing cigarette smoking. But we're worried that these lines may cross. Now I want to just point out for a second the sheer numbers here. So 313,000 versus 35,000. So clearly, it's a small percentage of the people diagnosed who die of their disease. Even a small percentage times a large number equals a large number. So that's a fact that we're going to come back to on some of the other slides. And as we've already heard, there is a concern, a very well-founded one, that Black men have a higher mortality from prostate among other cancers. And there's some interesting potential reasons for that we can get into in the Q&A. Suffice it to say, probably this isn't simply explained either by biology or access to care, but probably some combination thereof. Okay, number 2, everyone should get screened for prostate cancer. So I put over here on the left side the recommendations that come from the USPSTF, which is the government body that's responsible for grading different types of cancer screening. And over here on the right are some guidelines from the American Urological Association. Now, what you can see here basically is that it's not a one-size-fits-all approach. So according to the USPSTF, they give a certain grade recommendation to one age category, 55 to 69, and then a different recommendation for those older. And this is based off of their reading of what literature and evidence is out there. And they sort of present some of the benefits of screening and some of the harms of screening. These grades have changed over time, depending on what data is available to them. And importantly, the grade actually used to be worse for prostate cancer screening. And because of some interesting developments that we're going to come back to, some of the harms of screening are thought to have decreased. And so this grade was changed. Now, it's still been very hard to show that screening saves lives overall, but I think that there are some methodological challenges with our data, and it does seem to be the case that screening in general does seem to allow us to diagnose at earlier stages, which may be more treatable. It's also the case that many prostate cancers are ones that are basically the most indolent ones, the least fast moving, are the easiest to catch with screening strategies. Some of the more aggressive ones are harder to catch with screening strategies. Doesn't mean we shouldn't do it, but it does mean that this isn't a one size cures all approach. So over here on the right, you'll see that the AUA definitely factors in race in making this decision and giving a different threshold for the timing of all of this. Okay. Importantly, for the older men, this is the type of cancer that's very, very slow moving in most people. It's the kind of thing that develops over years. And so in order to benefit from screening, oftentimes we need to target a population that doesn't have a lot of other medical problems and has a kind of longer life expectancy. I should emphasize that screening really means a patient who doesn't have any symptoms. If you have symptoms and you're getting that checked out, then it really is not called screening. That's called making a diagnosis. Okay, so the next thing I wanted to talk about here is getting tested and sort of what the downstream implications of that might be. So traditionally, we would screen people based off of a blood test called prostate-specific antigen, PSA, and there was the much feared digital rectal exam, which was doing an exam in the rectum to feel the prostate. Just for anybody who's fearing prostate cancer screening, this has really been kind of taken out of guidelines. If people have symptoms, again, this has a role for helping evaluate those. But as a screening test, it's not a very good one. So in any case, mainly this was about PSAs that were above whatever was considered normal. And that would lead to a biopsy, which would lead to a diagnosis, and so on down here. Increasingly, we're actually using MRI to help make the decision about who even needs a biopsy. And this is just a picture over here on the right of what that MRI might look like. And so even though the pictures might look a little bit grainy to us, to a radiologist, they can look at these different patterns and say, what's the degree of suspicion that there's something that's actually what we call clinically relevant? Not just a prostate cancer that doesn't really need to be diagnosed or something that is unlikely to be prostate cancer. So as we go up here, we're starting to get a higher degree of suspicion. And so we're increasingly use this to kind of triage who does and doesn't need a biopsy. For people who have higher risk lesions, they go on to get not just a whole set of standard biopsies, but also ones that actually target a high risk lesion. So they'll take multiple cores out of that area in addition to, of course, from the rest of the prostate. And then for a patient who actually has a negative or very low risk MRI, that patient might just get PSA surveillance and might not need a biopsy. I should also emphasize that even when we make a diagnosis with prostate cancer, A, that doesn't automatically mean someone needs treatment. And B, the treatments that we do have, while they do have some potential side effects, it certainly is the case that most of our patients are living relatively normal lives and not experiencing a daily bother from their symptoms. And those who are, we try to do something about it. So this kind of gets at that question of what would happen to me downstream. And this is a very complicated figure that you don't need to understand. But basically what I'm trying to illustrate here is that it's not a one-size-fits-all approach. We used to think of prostate cancer as one diagnosis, and everybody would get treated kind of the same way. And probably what we did is we were over-treating a lot of people at the low end of the spectrum. These are patients who we now know probably don't need to automatically be treated. We can probably watch those patients very carefully and act if and when there's a change. Whereas patients who are at the higher end of the risk spectrum are the ones that we try to target for definitive therapy, which would include either surgery or radiation. And we can get into more about these modalities if folks are interested. But it certainly is the case that most of our patients who are going through surgery and radiation are coming out on the other side, again, not dealing with significant leakage, erectile dysfunction, etc. I'm happy to talk more about how we do handle those situations when they arise. Okay, so next we're going to talk a little bit about PSA. So prostate-specific antigen is that blood test that I mentioned. It's actually kind of a tough diagnostic tool. The problem with PSA is that even though it's very specific to the prostate, it's not necessarily specific to prostate cancer. So prostates can make PSA for all sorts of other reasons. This happens if the prostate kind of gets irritated, if there's infection or inflammation in the prostate. As we get older, there's a condition that can happen called just BPH, which is a big prostate. This is the typical old man problem of having to go to the bathroom a lot and having a tough time with the stream. So there are a lot of reasons that PSA can go up and down aside from cancer. It's also the case that there's not a good cutoff that tells us, aha, yes, you definitely do or definitely don't have prostate cancer. So the upper limit of normal is usually considered about 4, and people above that are oftentimes thought of to at least merit more workup. But that could also be leading to some people, getting investigation who don't actually have prostate cancer. And there's some people who have PSAs lower that could have cancer. And so we try to do other things. We try to look at the size of the prostate and kind of normalize for that, and try to adjust for age and background. So there's some ways that you can kind of play with the number and try to make this a little bit better. But ultimately, we shouldn't tell patients or think that just because the PSA was high means there's trouble, or just because the PSA is low means there definitely isn't trouble. Okay, so certainly most patients walking to my clinic are dealing with a really scary word, which is cancer. And I think there's a real thought that cancer equals death, especially if someone were diagnosed with metastatic or stage 4 prostate cancer. Now, different cancers are very, very different. So prostate cancer is a very different disease from, say, pancreatic cancer, where pancreatic cancer really is tough to treat and really does have a limited life expectancy in many cases, unfortunately. So in prostate cancer world, the vast majority of patients that we're seeing will not die of their cancer, okay? And that goes even for those patients who have localized disease that is getting treated with surgery or radiation. Most of those patients are still going to die, just like everybody else, of cardiovascular disease, which I'm a point on that I'm going to come back to. We should still treat those patients because we don't want their cancer to be part of their lives, causing symptoms or limiting their life expectancy. But we shouldn't lose track of the fact that there's lots of other things affecting their health. For those patients who do have metastatic disease at diagnosis, or who have initial therapy and then unfortunately have a recurrence, even those patients, I'm treating them for years. Exactly how many years gets a little bit into the weeds of what their disease biology is and how well things respond to treatment. But I tell people I'm expecting years ahead. Sometimes it's not as many years as we would like, but we're hopeful to get as many years as possible. And so I'm showing here just some curves for one clinical trial that was taking patients with metastatic disease, giving them 2 different types of treatment. And you can see that even at the end of this 5-year follow-up, well over 50% of both of these treatment arms are alive. And, the medians are reached, many, many years later. And this is just a schematic showing all the different types of therapies that I, as a medical oncologist, have available to me, even when there isn't a role for surgery or radiation anymore. So a lot of different tools that we can pull out at different times in different situations to try to make, to give patients a longer lifespan and hopefully a better lifespan as well, not just quantity, but quality. Okay, another misconception here. I have no pain, so I can't have cancer. What do patients that I see in the clinic most commonly have? Nothing. Can't tell you how many times patients have said, I just don't understand my diagnosis. I don't have any pain. Cancer causes pain, doesn't it? The other thing that some patients do have are urinary issues, but sometimes this is from background issues, like an enlarged prostate, separate from the cancer, or a separate bladder issue. So, if patients develop new symptoms, we should pay attention to them, absolutely, and work them up. But it's also the case that, we shouldn't use lack of symptoms to exclude this diagnosis. And I'll list a couple of less common symptoms that can happen when patients come in late, that they haven't had any prior screening. We didn't know anything about what was going on inside of them. That's when patients can come in sometimes having painful bone metastases or painful masses in their abdomens. We can sometimes see weight loss, anemia or low blood counts, kidney failure if there's a blockage, or actually coming in with a broken bone as a first sign of cancer. This is all the stuff that we're trying to prevent by identifying patients early and treating those who need to be treated. Okay, so I think this is a very common idea that diet and exercise are really the key to preventing or treating cancer. And I really want to emphasize that prostate cancer is not anyone's fault. It's not because you ate the wrong thing or didn't exercise. It's really a disease primarily of aging, but also bad luck. And so I think sometimes this idea comes out of the desire to have a lot of power over something that can feel very disempowering. And I totally get that. But I've sometimes heard people kind of blame themselves, and I really want to make sure that people don't feel that way, and also that we get away from a sense of fatalism, like, oh, I've been eating fast food all my life, I'm just going to get cancer anyway, so there's no point in even thinking about it. So what can diet and exercise help? Well, there's some thought that perhaps this could help decrease the risk of developing aggressive prostate cancer. Some mixed data, and maybe prevent more indolent forms from becoming more aggressive. I think the most important things are really that it helps patients get through treatment better if their body is in better shape to begin with. So the patients who come in with a new diagnosis and have no medical problems or very few medical problems that are well controlled, those patients are really in a much better place starting out than a patient who has a lot of other problems that are going to impact our ability to give effective cancer treatments. And as I mentioned earlier, the number one cause in prostate cancer patients of death is still cardiovascular disease, just like everybody else. And so this is something that diet and exercise are definitely helpful for. And some of our treatments can actually impact cardiovascular health. And so I feel very strongly that people should use diet and exercise to address those elements. So it's not that diet and exercise aren't important. They absolutely are. But we just need to be careful in what it does and doesn't help. So there's definitely the understandable desire to get outside of some of the traditional offerings and maybe go looking for alternatives. And so I'm highlighting here one of the rarer studies that was actually done of supplements. I think one of the biggest problems is that we just usually don't have any data. And by data, I mean really a randomized controlled trial as opposed to something done in mice or something reported on an internet website without any real data backing it up. So this was a trial done in patients with relatively low risk prostate cancer, looking to see whether it could impact their risk of getting upgraded or dying of prostate cancer. And ultimately, in supplementing patients with various supplements that were thought to have beneficial effects on prostate cancer, none of them really did anything. And if anything, there was sort of a trend towards vitamin E actually worsening outcomes. So I think that usually as doctors, we don't necessarily have a problem with people looking for alternatives or complementary treatments, but we really caution people that we just don't know a lot about them. We don't even know sometimes exactly what's in them, even if the label says something's in them. You don't know that the quality control is that good. And so we shouldn't rely on that in place of traditional cancer therapies. Okay, so there is a very understandable worry about financial issues. And I think that's especially true for, older men who may sometimes, rightly or wrongly, perceive themselves as the financial backbone of their family. And I will say that most of our patients really are not taking significant time off work for treatment. Those patients who are getting their prostates removed might have a few months during which they're recommended not to do heavy lifting. For patients who are getting radiation, depends on exactly what type of radiation we're doing. Sometimes it's as few as like 5 treatments. There's some longer radiation protocols. Usually these involve basically coming in, having a designated parking space so you can get in and out of the hospital real quickly, basically getting on the table and getting right off and being done in 15 minutes. So people do this on their way to and from work all the time. And the hormone therapy that I give certainly doesn't carry any work restrictions, nor does radiation. Sometimes people think, oh, if I get radiated, then I'm going to be radioactive and I can't be around other people. That is definitely not true. You don't glow after radiation. So financial toxicity is a real problem. And this is something that we think a lot about and work a lot on with our patients. The biggest issue, especially in my world, is that some of our oral drugs are ridiculously expensive. Now, the list price isn't usually what the insurance companies are paying, and insurance companies may cover a substantial portion of the cost. But even 20% of a very expensive medication can be a real financial hardship. And so we have a lot of ways of trying to address that. There are these things called patient assistance funds. We have some excellent pharmacists who really help with the logistics of getting access to treatments. So we recognize that these are real challenges and we struggle with them every day. But we also have ways of addressing them. And finally, I wanted to go through some misconceptions about clinical trials. And working at an academic center, we're always looking to see whether we can do better and hopefully treat the next generation of patients with more effective therapies or less toxic therapies. And so we want to learn constantly. Very humbling aspects of my job is thinking a lot and then questioning that every day and saying, what do we really know? And then trying to do a study to clarify that. So sometimes there's this idea that clinical trials are for people who have no other options. It's sort of end of the line. And that's actually very commonly false. We're very commonly doing these all along the sequence of events in patients who are curable or in patients who may not be curable but still have a lot of other options. So we don't reach for these just at the very end. Similarly, some people think, oh, I can do this whenever I want. I can transition off of a treatment, or if I'm sick in the hospital, then I'll enroll in the trial. Clinical trials actually take some time to set up, and so they're best suited for people who don't have urgent symptoms, or people who are not able to spare a little extra time for some of the workup that needs to be done for them. So I try to be very careful with my patients on sort of optimal timing, and there's good times and bad times for clinical trials. So sometimes there's the idea that this is going to be something that is totally experimental, we don't know anything about. And that's actually, there's a very broad spectrum of clinical trials that are out there. There are phase 1 trials that do test very new drugs. Now, by definition, if they're getting to the point of going through all the effort and cost of setting up a trial, there's got to be some reason that they think it's going to be promising. Very often, phase 2 trials are testing drugs that have already made it through phase 1. We know a lot about the dosing and the side effects. We're looking to see how effective they are. Phase 3 trials are actually taking drugs that are very well characterized and maybe comparing them against a more standard treatment. Maybe they're trying to get a new FDA approval. And so there's a lot of different clinical trials across the spectrum of development. So some people assume that if you're doing a trial or a study, that means that there's going to be a placebo or sugar pill. I can't think of a study that I've been involved with in my past decade of practice that has been set up like this. There's almost always some either standard comparator arm or a study drug that's being added to a standard, something like that. But it's extremely rare for us to be offering placebos these days, unless there truly is nothing available. There's also the conception that, you're not going to know what you're getting. And actually, a lot of trials are not blinded. A lot of trials might involve so-called open label treatments where, you're assigned to something and that's what you're getting and everybody knows it. It's also the case that clinical trials are not always having patients forced into one arm or another through a process called randomization. Randomization is super important. It helps us figure out whether treatments are actually better than another treatment. Many trials are so-called single arm, where everybody gets the same thing. And again, you know exactly what you're getting. You're not being forced into one arm or another. So just a long way of saying that clinical trials are very diverse, and we shouldn't make assumptions before sort of diving into the weeds of them. So I hope I've been able to cover a somewhat broad spectrum of prostate cancer in a very short period of time. For me, this is something that I could talk about just about all night, all day. But I'm happy to take more questions on anything that comes up later in our session. And so you're going to hear a little bit more about AdMeTech. I'd like to just put in a quick plug for some support groups. Prostate Health Education Network, or prostatehealthed.org, is a support group specifically devoted to Black men with prostate cancer. They have a great web presence and a lot of great programs. I'm involved as a physician advisor for the Boston Prostate Cancer Support Group, which has an easy-to-remember website, bostonprostatecancer.org, all virtual meetings at this point. Great place for people to both support each other and hear from experts coming in to talk about new things in prostate cancer. I know the primary care doctors are not always easy to access these days, but if you have a good one, keep them, and definitely talk over risks and benefits of screening with them. Mostly community members. We've heard from some of the folks at the top of the session about how important it is to talk to friends and family members, church members, etc., so that the stigma is lessened and the knowledge is dispersed. So with that, I'll thank you for your attention and turn it back over.
Thank you so much, Dr. Einstein, for your expertise, for addressing some of the myths that exist, because that is a big inhibitor of people getting a proper and adequate treatment and care. And there's a lot of misinformation out there. Although I would say the glowing one caught me off guard. I didn't think that there were people who were still thinking that the treatment would leave you glowing. But thank you nonetheless. So now I'd like to turn it over to our partners at AdMeTech and introduce Dr. Faina Stern, who is the president and CEO of AdMeTech Foundation, and Emma Couillard, the manager of the Prostate Cancer Equity Program and Organizational Development.
Thank you so much, Mr. Hall. I'm grateful to everyone here for taking the time and being a part of this event. Just a couple of things. I will talk about AdMeTech in my formal presentation, but I would like to highlight a couple of points that Dr. Einstein has made. One, importance of early detection. I will show more data demonstrating that with early detection, about every man with prostate cancer is alive in 5 years. With late diagnosis, when metastatic spread is present, we usually have 28% of men alive in prostate cancer, but also quality of care. Dr. Einstein just showed that in his clinic, more than 50% of men with advanced prostate cancer are alive in 5 years. And that's the fundamental difference between experts like Dr. Einstein and national average outcomes when we are dealing with only 28% of men alive at 5 years after diagnosis of advanced prostate cancer. The second thing that I want to highlight is controversy surrounding PSA testing. It's a simple blood test, which is usually done a part of annual physical. Unfortunately, due to all kinds of federal concerns and guidelines, over the last decade, and not every primary care physician even offers PSA testing for men, Black men, men with history of prostate cancer in their family, etc. So it's of critical importance for men to know the risk if they're Black men, if they have family history of prostate cancer. It's critical during physical exam. If primary care physicians don't talk to you about prostate cancer screening, you need to raise this issue, and you need to talk to your doctor whether or not prostate cancer screening is right for you. It's critical. Third things, prostate cancer has unfortunately became controversial around what it is. It's a screening tool. It's not the diagnostic tools. We ran into an unnecessary biopsy and unnecessary treatment because we did not have accurate diagnostic tools that would enhance the value of PSA screening. There are such advances in precision imaging that we know if man has abnormal PSA testing, we can resort to very precise diagnostic tools and to know which man has prostate cancer, which man doesn't, which man has aggressive prostate cancer or non-aggressive prostate cancer we should not worry about, which man should have biopsy, which man shouldn't, which men should have treatment, which men shouldn't, what kind of treatment would be optimal for a specific man based on very precise diagnostic assessment, genetics, imaging, biologics, etc., blood tests, tissue analysis of prostate cancer, etc. So all of these developments of precision diagnostics have put past concerns about PSA screening into the dustbin of history. That's why it is absolutely critical. If you are not sure, if you have conversation with your physician, and at the end of the primary care physician, and at the end of this conversation, you're not sure what to do, it's absolutely critical to get clarity. And we'll be happy to talk about resource today, which is Prostate Cancer Equity Program, that created this kind of clarity that will help you get to the point of clarity with some of the best prostate cancer experts in Massachusetts, such as Dr. Einstein. At this point, I would like to sort of, because it's our first event, I would like to talk a little bit more about AdMeTech Foundation and why we are so passionate about prostate cancer and eliminating disparities. And the resource we've created, Prostate Cancer Equity Program, so that everyone can come to AdMeTech Foundation and we'll make sure you get the best care available today. We started actually using videos for my presentation due to all kinds of technical issues. And Emma, is it possible to start my video presentation?
My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My gratitude to Mr. Hall for the opportunity to present this first joint prostate cancer awareness event between AdMeTech and Urban League of Eastern Massachusetts. The focus of my talk is on the AdMeTech Foundation's history and our prostate cancer programs established to lead and implement the cutting-edge advances in patient care and to bring these advances to all Massachusetts men with the goal to eliminate health disparities. AdMeTech's ongoing statewide program in prostate cancer created a Massachusetts model of national leadership in public awareness, medical education, research, and health equity. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. We are grateful to Senator Miranda and other leaders of the Massachusetts legislature who have championed our programs and made them possible. History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of Diagnostic Imaging Research Branch at the National Cancer Institute. In this position, I was leading development of national and international policy and related strategy and programs for the National Institutes of Health, NIH, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound and molecular imaging for improved patient care. We also work on teleradiology for image transmission so that we could bring world-class expertise to underserved rural and remote communities. As of early 90s, most women had blind biopsies. Precision imaging made it possible to see where suspected tumors were located and develop stereotactic biopsies where biopsy needles are guided with precision to suspicious areas. As of early 90s, women with breast cancer have radical surgery or mastectomy where the entire breast is removed. A procedure performed in operating rooms causing physical, emotional trauma, pain, suffering, and deformity of women's bodies. Precision imaging made it possible to proceed with minimally invasive surgery or lumpectomy, where we identify and remove only a part of the breast tissue containing tumors. These minimally invasive procedures are performed in outpatient clinics with minimal complications, pain, suffering, and costs. As of early 90s, many women, particularly Black women, were diagnosed with breast cancer in more advanced stages and were more likely to die. With digital mammography and MRI, all women are more likely to have early detection of breast cancer, critical for saving lives. Today, Black women have a nearly equal chance of dying compared to white women in many communities, particularly in a state like Massachusetts with its universal access to care. In 1996, while our breast cancer programs were well underway at NCI and NIH, I brought together the key leaders of government, medicine, and industry to outline new strategic priorities. This expert recommended prostate cancer as the next priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer is among women. Prostate cancer strikes 1 in 8 men. Breast cancer strikes 1 in 8 women. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or the likelihood of men dying of prostate cancer. However, men did not have accurate diagnostic tools that would make it possible to sort out if an abnormal screening result is due to false alarm or due to a life-threatening prostate cancer. With no accurate diagnostic tools, many men had either insufficient diagnosis and treatment of aggressive prostate cancer with dangerous consequences, or on the other side of the spectrum, they had overdiagnosis and overtreatment of benign and harmless prostate cancer, leading to unnecessary invasive procedures with related life-altering complications and costs. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to a prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care and eliminating health disparities. At about the same time in 1996, I had a personal experience that left me shaken. A leading clinical expert in Massachusetts, chosen by me, saw my father and determined that he had a benign and common prostate condition. However, When my dad had an invasive procedure for this condition, he was found to have prostate cancer. I was shocked that a leading expert in a world-leading hospital did not have diagnostic tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of this disease for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I organized other leaders of medicine, and we approached NCI and NIH, key leaders, in a hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track record and a year-long effort, we did not succeed in convincing federal government. Consequently, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. Since 1997, we have been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other diagnostic tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate Imaging for Men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity and public health priority. By 2013, again per our advocacy, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a standard in patient care. Since 2014, we expanded our efforts in public awareness, reaching countless men. At that time, Plymouth County had the state's highest mortality in Black men and the highest disparities. Black men in Brockton and Plymouth County were 2.7 times more likely to die compared to white men. We joined efforts with Brockton NAACP and Good Samaritan Medical Center. Under the leadership of Steve Bernard, Phyllis Ellis, Leona Martin, and Janet Trask, Brockton NAACP ensured a broad community engagement, mayor's office, city council, local media, and multiple local community organizations. By 2021, we had seen a significant reduction of overall prostate cancer mortality for all men in Plymouth County, but a particularly great impact on Black men. Since that time, we have seen a significant drop in health disparities in Plymouth County, while health disparities at the state level have not really changed. Today, Black men's chance of dying of prostate cancer compared to white men in Plymouth County dropped by more than 50%. In 2016, we established Global Summit for Medical Education with the goal to integrate imaging with other emerging diagnostics, including molecular and genetic testing, to ensure precision care that was tailored for individual men. Similar to breast cancer, precision imaging paved the way for image-guided, minimally invasive treatment for prostate cancer. Similar to lumpectomy, these minimally invasive procedures can be performed in outpatient clinics with minimal complications, discomfort, and cost. Several years ago, in 2021, we created Prostate Cancer Equity Program to deliver high-quality, world-class patient care to all men in Massachusetts, with the priority focus on Black men. For public awareness campaign, our messaging centered on the importance of screening and early detection with blood test PSA, critical for saving lives. Since 2019, we reached well over 60,000 people. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same period of time. PSA blood test used for screening of prostate cancer has been more successful in reducing the loss of life than any other cancer screening tools available today. Screening and early detection of prostate cancer are the best equalizer for all men. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. There is not a corner of the world that has not been represented at our summit. The latest 8th annual conference took place only a few weeks ago. Our summit concluded that equal access to high quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It's particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and multiple branches of NAACP located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities, particularly when combined with our large-scale public education and awareness campaign. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in our program take care of our families and friends. This process consists of 3 main components. First, AdMeTech Foundation team members collect basic information and match individual patient needs with the appropriate state experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.
Thank you again for your attention. And it's a great pleasure for me to introduce Emma Coyer, manager of the Prostate Cancer Equity Program. Emma?
Hello, everyone. Again, thank you so much for having us. And as Dr. Stern said, I am the manager of the Prostate Cancer Equity Program. So I'm the first person that you would speak to if you were to email the program or call the number. I talk to a lot of patients, and it's really personally rewarding for me to help them through every aspect of their care, helping them with their scheduling, transportation, translation, their health insurance, any problems that may come up. So I'm going to put my information in the chat. If you or any of your friends or family are interested in this program and would like to learn more, please feel free to reach out to me. And for the next part of the program, we're actually going to hear a patient testimonial from someone who has been through the Prostate Cancer Equity Program. His name is Kenneth Reeves. He's the current president of the Cambridge branch of the NAACP. He's a wonderful man, and he's now going to share a little bit of his story and experience with AdMeTech.
My name is Kenneth Reeves. I am the president of the Cambridge branch of the NAACP, as well as the former mayor of the city of Cambridge, Massachusetts. My intention is to say a word about the AdMeTech Foundation and its offerings and benefits, particularly to communities of color and particularly to Black men facing issues with respect to prostate cancer. I would say that in Cambridge, we've been in the men of color health business for more than 25 years. And so we have a men of color health outreach. However, I think we've become much more knowledgeable about ways in which we can assist the men of our city. And we particularly have become much more knowledgeable about prostate cancer and its impact on particularly Black men, who are 5 times as likely to be affected by prostate cancer than white men. So that being the case, and I've dealt with prostate cancer theoretically, and then 4 years ago, I was diagnosed with prostate cancer. So I have my own journey. And after diagnosis, I was able to hear what my treatment options were, and I chose something called CyberKnife, which is a 6-day treatment where you go every day for about an hour. There is a laser approach to the cancer. And after that, I was able to be clear for almost 2 years. And then suddenly my PSA, or prostate specific antigen number, kept going up, and no one could figure out why. And I had many MRIs and other tests. And that's when I met AdMeTech, because I was describing this to a friend, and they said, "It sounds like you're lost in the maze of, what to do when your numbers are inexplicable." So I was in touch with our Dr. Stern, and basically I had to tell her there is a test that they don't have in Boston that I need to have. It's an imaging test that's very advanced. It's in Europe, but not yet approved by the FDA. And she said, I'll get it for you. And she was able to arrange it through Sloan Kettering in New York. So after much red tape and bureaucracy, I was able to get that imaging test, and it did find where the prostate cancer had moved to an area around my lung, which my doctor, who's a very important, famous department head at Dana-Farber, said he had only seen one case in his career, so he was pretty sure it wasn't to the lung. So I then learned that, the physicians are great, but they're not God. So I called him and said, guess what? I'm number 2. And after being number 2, I still have had to have these various questions that I don't feel competent to answer about what next steps should be in my medical care. So while I have a wonderful team at Dana-Farber, who Dr. Stern led me to, but even in all that wonderfulness, there are questions that I don't feel competent to answer. So she just 2 days ago helped me to answer 2 great big questions. So I think this is timely for you to hear that. In my big questions were whether I should participate in a particular study, which would, I'm now on a very expensive pill that has my PSA number at 00000. So this is $16,000 a month. And the question asked of me by my doctor is whether I would participate in a trial which would essentially stop this pill, let the cancer come back, and then observe what that does with respect to the testosterone level. And the doctor also said, well, we don't get many Black men in trials, so we'd like to get it would be important if you were to say yes. And so this was hanging over my head like a cloud. I couldn't decide because I want to do whatever I can do that will be helpful to both science and to prostate cancer with respect to Black men, because self-interest is a wonderful motivator. Her immediate reaction was, not for you, because you had one of only 2 cases with your particular doctor. The experience with people like you for such a trial is too small. And so you should be very thankful to the doctor, but it's not for you. Thank God for having a foundation that's devoted to navigating men of color through the maze of prostate cancer to be able, with a scientific point of view, give that kind of direction and consultation. So I must say that is great.
Emma, thank you so much. And I hope you will put your information in the chat so that people will know how to reach you in case they are wondering whether or not screening is right for them, if they want to get access to the leading experts, either as initial care or a second opinion if they were recommended biopsy or not. They're not sure if they need biopsy, if they were recommended treatment and they're not sure that this is the kind of treatment that will work for them. At this point, I'll be I'm sure Dr. Einstein and I will be happy to answer any questions anyone can have. So will Emma. Do we have any questions? Thomas, any questions on Facebook? While Tom is looking again, I would like to highlight take-home point, and that is we cannot prevent prostate cancer a day, but all of us are in control whether or not prostate cancer can be diagnosed early. And that is, and what is critical is to make sure to talk to your physician about prostate cancer screening, even if your physician does not initiate this conversation. I think we have a question in the chat. Any thoughts about the new urine tests for screening? David, do you want to address this question?
Sure. I mean, this could refer to a couple of different things. There are certainly some tests that are purported to help make the decision about who does and doesn't need a biopsy. And then there are other types of urine testing that are more in the research phase at this point, having to do with looking for little pieces of tumor DNA, whether we could use that to kind of get at some of the disease biology in prostate cancer. I think that biomarkers are fascinating and also challenging, and so for making the decision about who does and doesn't need a biopsy, probably the biggest change that has happened in parallel is the role of MRI, which both of us touched on. And so then the question becomes, do you need multiple tests to help you make the decision about biopsy, or is one test better than another? So I'd say at this point we've mainly integrated MRI in that because we have kind of the best data for proving who does and doesn't need a biopsy. I think the urine tests are interesting, perhaps might have an adjunctive role, but it's not something that we're routinely using at this point. Certainly something that more research could help us with.
I agree. And usually additional blood tests, additional to PSA testing, diagnostic tests or diagnostic urine tests, they're looking for more precise molecular markers identifying prostate cancer. And they're more in an experimental kind of stage right now. But what the current research shows that when you integrate these molecular markers in urine or blood with MRI, you actually have, you may have a more accurate way of assessing whether or not each individual man needs biopsy or treatment or what kind of treatment. Any other questions? Did they address your question, Joe? Okay. Any other questions? Okay. Mr. Hall, back to you. It looks like we do not have any more questions.
Well, if there are no further questions, either on this Zoom or from Facebook, we'd like to close this session out. Again, I would just like to thank our partners at AdMeTech for not only partnering with us on this event, welcoming us into this space, but for all of the great work and awareness raising and advocacy within the legislature to really address the concerns around prostate cancer and particularly the racial disparities that exists. It is such important work, and it is always important to have valuable and well-respected champions for these issues. And so we are thankful for those who have tuned in. We encourage everyone to take advantage of this information, share this live stream on Facebook and wherever else it is posted. The Urban League will certainly be pushing it out because the more people who have this information, the more people who can live fuller and healthier lives. So thank you all for tuning in. Thank you, Dr. Stern and Dr. Einstein and Emma. We appreciate all of your insight and expertise and the information that was shared. Thank you all.